Association of Endodontists, on their case difficulty assessment form, considerate the radiographic appearance of the canal as an important aspect to consider before designing each case as a medium or high difficulty. If the canal is visible but reduced in size, or if it has a pulp stone, the case is considered having medium difficulty. On the other side, if the canal path is indistinct, the case automatically becomes one of high difficulty. Surprisingly, despite being an old topic, there's not much literature regarding outcomes on this particular calcified teeth. The few existing on the subject concludes that our success rate is highly dependent on the occurrence or not of iatrogenic errors and their resolution. Iatrogenic errors that you will see along this presentation that might be a reality every time we approach a case like this. This is one example where we can see that a false path while approaching this calcified upper incisor led to a perforation as seen on the CBCT slice, leading to a sodium hypochlorite accident ending unfortunately in extraction due to a non-restorable fracture of the tooth due to the big and invasive destruction caused by the wrong access. The truth is that today we know from data recovered from many studies that of the reasons for extraction, endodontic reasons is one of the least common. Most of the teeth are extracted due to large carious lesions, post-endodontic non-restorable fractures, or periodontal reasons. So every time we approach a case, we need to be as conservative as possible, which is a real challenge in case of calcified teeth. Today we know that pulp calcifications is a common occurrence. Although estimates of the incidence of this phenomenon vary widely, it is safe to say that one or more pulp calcifications are present at least 50% in 50% of all teeth. And this high prevalence is mainly due to its etiology that can be physiologic, by natural aging, or due to a response to aggressions along all our life. Today we won't have time, nor I am the best guy to talk about all these factors in detail. Only refer that it's normal to expect a significantly reduction in pulp cavity size coming with age due to a lifelong deposition of secondary dentin. We see that every day in our practice. On top of that, our teeth are constantly through life submitted to several of aggressions that accelerate this deposition of secondary dentin or induce the formation of tertiary dentin. Okay, so examples of those aggressions are caries, restorative procedures, vital pulp treatment. It can be responsible for a pulp canal obliteration as seen on this pulpotomy done by Mário Martins. We need to understand calcification as being a vital response to a stimulus and therefore having no pain, no radiographic evidence of pathology. This case has no indication for further treatment, even if it's non-responsive to pulp tests. I just want to highlight dental trauma as the main reason for the development of calcific metamorphosis, a vital pulp response characterized by rapid, fast deposition of hard tissue within the canal space. In reality, approximately 4 to 24% of traumatized teeth can or may develop varying degrees of pulp obliteration. That obliteration can be partial if only limited to the pulp chamber, or complete obliteration if extending also to the canal. The result is probably a tooth showing reduced pulp space associated with an altered, a changed yellowish color, more or less 3 months to a year after the traumatic episode. Andreasen, in one of the most cited papers about dental trauma, observed that the occurrence of obliteration varied depending from the type of trauma, represented, that you can see represented by the green bands on the graphic,